So while you're getting settled, I'd like to acknowledge and thank the sponsors for the conference. Certainly, I want to thank the platinum sponsor, and that is Mayo Clinic. So if you're at Mayo Clinic, will you wave your hand? Help us thank them. I'm at Mayo Clinic too. So we also have at the gold sponsor level, we have Mercy Care Plan and Mercy Maricopa Integrated Health Healthcare. Help us thank them. Are they in the room? All right, thank you so much. At the silver sponsor level, we have South Phoenix Healthy Start. Are they in the room? By a show of hand. Thank you so much. And then we have several bronze sponsors. If the Southwest Interdisciplinary Research Center at ASU is here, please wave your hand. I saw a couple of my colleagues. Help me thank them. The University of Arizona College of Public Health, the Mel and Enid Zuckerman College of Public Health, thank you if you're in the room. Is Phoenix Children's Hospital present? Thank you for being here in your sponsorship. First Things First. Thank you. Living Out Loud Health and Wellness Center. Thank you for your sponsorship. St. Luke's Health Initiative. Thank you for your sponsorship today. I saw a couple of folks from there. And then on page 4 of your program, that's where all the sponsors are listed. We also have the continuing education credits sponsor there, as well as in-kind support sponsors that are there. So thank you to all of you. This could not have happened without you, and we certainly appreciate your sponsorship and look forward to your sponsorship next year. Just a little plug for the fundraising that has to go into this. We are certainly delighted to have an esteemed panel that I will introduce today, and certainly appreciate their presence. We have 4 special guests that are representing 2 free medical clinics and 2 federally qualified health centers from around the state to discuss access to care. And most specifically, and these are not in order, but I'll try to get them in order. To my left is Catherine Amiot, and Catherine is the Executive Director of Mission of Mercy here in Phoenix. Thank you for coming, and help me thank her for being here today. And to her left, we have Dennis Huff, Behavioral Health Director at Native Health in Phoenix. Thank you, Dennis. And to his left, we have Catalina Laborin. She's the Outreach and Eligibility Manager at El Rico Community Health Center in Tucson. Thank you. And on the very end, the left bookend is Eric Walden, and he's the Executive Director of Poore Medical Clinic in Flagstaff. So how this will work, we'll have each speaker will share 10 minutes on 2 things. 1, their region, the population served, and then 2, the description of their organization, and 3, details about the various needs and opportunities to partner. And then we'll just go directly down the table. After all 4 have shared, we will have 20 minutes for audience questions for our panel. So we will start with you, Catherine.
Good morning. Can you hear me? Yes? Good morning. I'm Catherine Amiot, and I'm the Executive Director of Mission of Mercy. And I want to tell you just a little bit about our clinic and who we serve, and we'll kind of get into a few details. Our first slide is really a definition of what Mission of Mercy does, and I want to mention that we've been serving the Valley since 1997. We are a network of primary care clinics, and we provide services to the uninsured and underinsured populations throughout Maricopa County. We provide a healthcare safety net, access to care for thousands of individuals and families, and we consider ourselves part of the solution to Arizona's health crises. I will mention that our patients, for whatever reason, are those that do not qualify for other programs. And I know there are a number of other programs that are represented here in the room. Our patients do not qualify for those programs. Many of our patients are undocumented, and therefore they cannot access health care through the government exchange. So we are the clinic of last resort here in Maricopa County. I want to just share with you a moment what our core commitments are, and our programs are really organized around these commitments. First and foremost, our commitment and our mission is the restoration of human dignity. So our first core commitment, of course, is restoring dignity. No one is turned away from our clinics because of their legal status or their inability to pay. Empowering patients. Through our Community Connections program, which is run by Diane Aguilar, who is in the room with me today, patients are connected to supplemental resources, including chronic disease management classes, free mammogram screenings, and many more additional specialty care services, either on-site or off-site. Over 60% of our patients suffer from chronic illnesses, primarily diabetes, hypertension, asthma, heart disease, and complications from obesity. All of our clinics are bilingual, and we assist our Spanish-speaking patients throughout the entire patient visit and education process. All of our classes are provided in both English and Spanish. I will mention that our patients, for the most part, are Latino. About 85% of our patients are Hispanic, that is their first language, and 98% of our patients report that they are uninsured and or underinsured. Our last core value is strengthening communities. And this is really the changes in the healthcare landscape are calling for innovative partnerships with specialty care providers and the traditional hospital community. All of our clinics are 100% privately funded, so we take no state or federal money. We are not an FQHC. We are a privately funded, private 501c3 organization. There is no pre-qualification of any kind for our patients. This is why we can accept patients that do not otherwise qualify for other programs. As I was hearing Dr. Shah's presentation this morning, and she was describing Victor, the diabetic who was making difficult choices about feeding his children or buying his insulin, that's a classic patient of Mission of Mercy. We see that every day. All right, our patient demographics. I did a side-by-side slide because it shows a 10-year span between our summary of services in 2005 and what we're seeing now. And the most striking change is that we're seeing fewer children. There's a couple reasons for that. When we started in 1997, we were really a precursor to what is now kind of the urgent care model. We had an emergency room doctor who was volunteering his time, and we were treating very episodic 1 to 2 visit types of patients, lots and lots of children. Over time, we realized there was a shift in our patient population from that urgent care episodic model to many adults who were suffering from chronic illnesses. So what you see in our current summary of services is quite different. We still treat a lot of episodic illness, but the bulk of our patient care is now around chronic illnesses. In Arizona, 1 in 5 Arizonans are still considered uninsured, and 1 in 4 are considered underinsured. This is a new class of patients that we are seeing, the underinsured, those who might have access to some very expensive out-of-pocket copay type of policy with very high deductibles, and they're accessing basic health care at the same rate as the uninsured. So we've expanded our definition now as the medical home for not only the uninsured but also the underinsured. Okay, let's talk a little bit about impact. One of our primary goals is to reduce costs on Arizona's healthcare system. We do this by serving as the primary medical home for thousands of insured, uninsured, and underinsured families. Because we use volunteers so extensively, we only have about 4 full-time paid staff, and we will treat this year we'll provide about 15,000 patient visits. We'll dispense more than 25,000 free medications with an extremely small staff augmented by many, many volunteers. This keeps our per patient visit cost to a mere $71.17 as compared to several $1,000s if those patients were to end up in a hospital emergency rooms. One of the things that we are working very hard on is to create a preventive medicine and chronic help program. So we want to support our education program and empower our patients through bringing services onto within our clinic and partnering with others so that we can create a continuum of care and be that resource hub for our patients who would otherwise use hospital emergency rooms for their primary care. We are part of our community solution. Since we started in 1997, we have provided over 200,000 free patient visits, and we have provided over 300,000 free prescription medications. We have no barriers to care. We strategically target Maricopa County's most vulnerable communities. We utilize, actually that number is more than 325. I checked it yesterday. It's closer to 400 volunteers of all kinds, both medical and lay volunteers, to create clinics throughout Maricopa County. Last year, we recorded an astounding 18,140 pro bono hours at a value of over $850,000. This year, it looks as though that number will go over $1 million. So we are very, very volunteer-oriented. And finally, what we are committed to in our next steps are pursuing innovative partnerships with the broader healthcare community, recruiting additional volunteers to serve our growing number of patients, which, by the way, has grown 40% in the last 4 years. We want to expand the number of customized emergency room, diversion medical home partnerships, which we fortunately do have with Dignity Health at this point, that provide access to primary care for discharged patients who lack a primary care physician or other access to supportive health care services. We want to expand our Community Connections program to include dental and mental health services. And we want to engage the broader healthcare community to create a 3 to 5 year access to care roadmap where we work together in a collaborative way between the traditional healthcare organizations and other nonprofits. And we want to secure additional earned revenue streams to provide for the expansion and sustainability of Mission of Mercy's clinics, both locally and throughout the state. Thank you.
Good morning, everyone. Native Health is a FQHC located here in Phoenix, and even though our name says Native Health, we actually serve anyone who's eligible for services, regardless of race. Before I begin with my explanation and sharing a little bit about who we are and what we do, and a little more about who we serve, I'd like to share with you some information that came across my email earlier this week that I thought was appropriate. part of this is some statistics, and they're a little bit old, and I know they're actually a little bit more serious, maybe the term to put. But I want you to think about these. And a lot of my experience has been working on the behavioral health side with persons living with and impacted by HIV, so I'm kind of coming from that area right now. But I'm going to read just some statistics and want you to just think about it for a minute. 1 in 3 black MSM will receive an HIV diagnosis. 1 in 3. Domestic violence doubles the risk of death for women living with HIV. Latino Hispanics have the lowest rates of insurance access. Trans women have a 1 in 12 chance of being murdered, or a 1 in 8 chance if you're a trans woman of color. The lower the income, the higher the HIV rate. 46% of blacks and 40% of Latino Hispanics live in poverty, compared to 10% of whites. At the end of 2010, the South accounted for 45% of the estimated new AIDS diagnosis in the United States, followed by the Northeast at 24%, the West at 19%, and the Midwest at 13%. Having said that, I'd just like to, first of all, thank Dr. Shaw for the feedback on her study. And I think I just want to make a statement to go a little bit further, that health equity is a civil rights issue. And until we acknowledge that, until we include that in our discussions, I think we'll continue to be talking about disparities, because civil rights has to be a part of that discussion. Kimberly Crenshaw from the National Minority AIDS Council talked about intersectionality. She said, intersectionality is the study of intersections between systems of oppression, domination, or discrimination. It holds that systems of economic inequality, racism, bigotry, homophobia, transphobia, and sexism do not act independently of one another. Intersectionality has given many advocates a way to more accurately frame their circumstances and communicate the complexity of the work they do. The power of acknowledging intersectionality is that it illuminates the holistic ways that people experience the world. As an FQHC and a community health center serving the community, we have to recognize these issues. We can't just focus on the medical, the behavioral health. People come to us with stories and with histories, and our job is to be able to address them. At Native Health, a lot of the services we provide, we're fully integrated healthcare system at our agency. We have primary medical care. We provide dental care. We have behavioral health that includes mental health services, alcohol services, and a fully integrated behavioral health team that is embedded in our medical clinics. They actually work with our primary care providers and the patients, and work with persons presenting with behavioral issues related to their health care right in the exam room. So that reduces the possibility of that 50% dropout that typically happens from external referrals to other resources. We also have a community wellness program that includes HIV prevention as well as integrated HIV care, working to make sure that not only are the health issues of persons presenting to the agency or our medical clinic addressed, but also that the behavioral and emotional needs of those persons living with HIV care are being addressed as well. We also provide Arizona long-term care services. We have a home visiting program, Health Start, and a WIC program. Our agency has several clinics currently. We're in Central Phoenix, right at Indian School and Central. And we also have a West clinic, not quite as west as we'd like to get yet, but that could be the future for us. But we're also located at Dunlap and I-17 on the west side of town. And as I'd mentioned, all of our clinics are open to the persons we serve, so all are welcome. As a federally qualified health center and a 330 funded community health center, we also offer a sliding fee scale for persons based upon their ability to pay. We accept access insurance, private insurance. There's also no fee for Native Americans with tribal ID or a certificate of Indian blood. We have a comprehensive medical and dental program. We do not turn away people based on their ability to pay. And again, to go back, we do partner with all people. Some of the partnerships as an agency that we have, and this list is not extensive or inclusive of everyone we partner with, but it shows you who we work with in the community and what we do in the community. We work with Midwestern University. They provide on-site podiatry, optometry services for us. We have diabetes programs that we work with. More importantly, though, as a community health center, based upon my opening remarks, we also have to be cognizant of who is not on our partnership list. And these are the people we need to bring in to work with us, and community health centers need to work with, to be able to address issues of racism that's inclusive of the disparities with the people we're working with. Partnerships are key. Who you bring to the table as partners, is even more important. And you have to make sure that the people you bring and partner with have a voice at that table as well. Our board of directors is over 50% Native, so we do represent the Native community with our board of directors. It's a community board, so it's also a group of people who happen to be users of the services we provide as well. And that becomes important for us. We have an instant messaging system for our patients. There's a little sign on most of our exam rooms, our waiting areas. They can send a little text saying how they're being served that day, or what challenges they're seeing, or what's going on. And they get an instant response back to that message. And that's how we provide feedback as well. Then our job as providers is to be able to make the needed changes to make sure that we're accommodating the people we're serving. So with that, Native Health is in the community. We're working right now on expansion in the East Valley. We see an area of health disparity in the Mesa area that we're going to be working at and helping to build a system of care there as well that hopefully will be just as comprehensive. And at some point, we may even be looking further west as the need is even more so out there. We are part of the Alliance of Community Health Centers. We're one of the 3 or 4 of that group that are actually accredited by the Ambulatory Association or by the American Association of Ambulatory Health Care. And so we're proud of that, and we're also proud of the fact that we have the Patient Center Medical Home designation, which means we really do look at the needs of the patients we serve and try to make the constant changes and adjustments that requires. Thank you.
Hi, my name's Catalina, and I'm from El Rio Health Center. I wish it was Rico, but no, El Rio. And I would like to start by saying it's a privilege to be here. I'm so excited. Usually I'm always talking to my family about El Rio and about all the different things that we're doing. So I have Max, my son, my 7-year-old, has to be the most educated little boy on Medicaid, on Medicare, on sliding fee, and dual eligible. Okay, and when we're in the dinner table, he's always saying, Medicare, Medicaid again. So it's really nice to be talking to a captive audience that knows what I'm talking about. Okay, so El Rio Health Center, we have actually 16 different sites, and that's including our administration. El Rio Health Center has been open since 1970. Not only that, but we still have the first employee that El Rio has had since that. So, we've been there for a long time. El Rio Health Center opened to serve patients in 1970 as El Rio Health Santa Cruz Neighborhood Center. The population during that time was to service the West Side area, which really didn't have that many services. And it actually started by the U of A. so we're really excited. It was incorporated in 1974 as a private company, as a private nonprofit. We're also a federally qualified health center, and it's governed by a board of directors. We never refuse anybody health care. And we also use our sliding fee scale. And, I'm getting so excited here. Actually, the number, right now, we have over 85,000 patients. So right now, one of every 12 people, Tucsonians, actually go to El Rio. I'm proud to say that my whole family goes to El Rio. So you can tell, right? You can't say what a great place you work in if you don't go there. So I'm really excited. I always get second opinions because we have so many doctors. So one of the things that, and if you can see in this chart, the majority of our patients are Hispanic. And in Tucson, it's always been like this, but now it's like we're seeing more refugees than before Tucson. Do we have any native Tucsonans here? We do. Do you remember back? If we just go back 20 years, we really didn't even know what refugees were. And the thing is that now we're working with a different population. And so that's, we're trying to accommodate that, what we're seeing now. This is where my area comes in, and you'll see me all excited. And this is because look at the uninsured. Right now, that was in 2014. Actually, we have reduced that to 12%. And that's because with the eligibility, the open enrollment, with the marketplace, the access expansion, actually, this is going to be our 3rd year. So what happens? Did you guys ever see The Candidate? Robert Redford? No? No? Yes, you saw it, right? So after he wins, he says, what am I going to do? So actually, we did all the perfect things. We did everything to enroll our patients. Last year, we did over 28,000 applications for access. So now we have all these patients, and now we're seeing that our work is not done. It's just started. And this is one of the things is that we hardly talk about is that we have people that have insurance or they're in the marketplace, but yet, guess what? They do not know how to access the services. It's not because of lack. They have insurance, but now we're starting in a new phase, and that phase is to educate our patients. We've been so focused in outreach, enrollment. Guess what? Education, educating our patients. We see with the marketplace, this is our 3rd year. Our 1st year, my husband was going to divorce me because it was so terrible. But the thing is that the 2nd year, we saw that it was so easy, right? The 3rd year, this is our 3rd year. But we're finding out that our patients are coming back to us. Our patients have health literacy, low health insurance, health literacy. So the thing is that it's really hard for them to understand what copays, premiums, deductibles, out of pocket. I mean, they don't know. So now this is the new thing that we're doing at El Rio. We're educating our patients. We're starting classes on how to use services. It's not just to get them enrolled, but now it's to understand to access the services. What do they need to do? Sometimes these people are coming into us, they have Medicaid, they have access. Guess what? They had no idea they had even applied for it. So now we're educating our patients. So this is a new phase that we're going through. It's not just the enrollment, not just getting them insurance, but educating on health literacy. Thank you.
Good morning, I'm Eric Walden from the Poore Medical Clinic in Flagstaff. We are a community-based, free medical clinic. We were founded by Dr. and Mrs. Poore, as you see on your left. Dr. Poore had practiced medicine in the state of Arizona for over 50 years at the time he founded this clinic. We're 4 years old. The gentleman on the right was a key player, a community volunteer helping get the clinic started and off the ground. Our mission is to provide primary medical care to uninsured residents of Coconino County. These patients receive their care for free. There is no cost to the patient, there is no sliding scale, there is no co-pay, there is no minimal charge. We serve Coconino County. Coconino County is the second largest county in the country based on area, not population, but based on area. Okay? Poverty level in Coconino County is 23%, people living below the poverty level. As a point of comparison, Maricopa is 16.7%, Pima County is 19.2%. Who's been to Flagstaff before? Raise your hand. Anybody been to Flagstaff? Woo, okay, great. Beautiful time of year up there. Colors, fall colors. It's cool. Get out of the valley heat, right? Go up for some winter sports. Some challenges living in Flagstaff. The wage base in Flagstaff is about 80% of the national average for similar type jobs. Cost of housing in Flagstaff is about 125% of the national average. So people are trying to survive there on a 40 to 50% split of what you can earn and what it costs to live there. Great challenges. Locals up there who live there have a phrase for it. It's called poverty with a view. That's true, they say that. Now, that's not the Chamber of Commerce slogan, mind you, but that's those of us who live there do say that. So it puts a lot of pressure on the healthcare system when the cost of living is so high. Population of Flagstaff, well, the poverty level of Flagstaff, we said Coconino County was 23%, Flagstaff's poverty level 24.6. Population of 68,000, you're talking 17,000 people, men, women, and children living at or below the poverty level in the area. Most of our patients are the working poor. Now, in the warm months, we have a lot of transients living in the forest because we are surrounded by state land trust and national park service and forest lands. And we see some of them, but overwhelmingly it is working poor. It is people who are trying to make those ends meet. We are not a walk-in clinic. We do not provide urgent care. We provide primary care, so we are by appointment only. You have to be screened to make sure that you meet our 3 criteria of you're a resident of Coconino County, you are living at or below 200% of the poverty level. That is our line. And we ask our applicants to prove that to us either with a pay stub or a tax return or some sort of tangible evidence of that, and that they have no insurance whatsoever. Your initial appointment at the Poore Clinic with a physician lasts 1 hour. When's the last time you spent an hour with your primary care physician? In an appointment. I don't mean a cocktail party, but I mean in an actual clinical setting, right? Succeeding appointments are a half an hour. And if there's a procedure scheduled and it's an odd amount of time, we schedule that for the appropriate amount of time. Everybody is screened to determine their eligibility by our criteria. We do have limited hours. We see patients for clinic visits on Tuesdays and Thursdays, 6 hours each. We have screenings on other days, so we're not open all the time. We're closed on Fridays. I know that there are some nonprofit healthcare systems here and other organizations here today, and that's great. This is a shoestring. This is also our operating budget.
Yep.
Okay? So last year, our operating budget was $137,000 for the year. How in the world is that possible, you may ask? All of our doctors and nurses and practitioners and medical assistants and dentists and hygienists and dental assistants and office staff are volunteer. We are a 100% volunteer organization, asterisk, except for me, but I'm new. Okay, the organization's 4 years old. I started in April as executive director. It is a part-time position. And Dr. Poore is now retired, and he and Mrs. Poore were looking ahead. They are in their mid-80s, saying, we want to make sure that this clinic continues its service to our community. So they've brought in and hired their first ever paid staff on a part-time basis. We are a 501c3 nonprofit organization. We have a board of directors of 10 people. We just opened a second location last year, which has now our dental clinic. So our dental clinic is about a year old, and overwhelmingly, there's a tremendous need for that. In fact, we have an issue of trying to find enough dentists to volunteer their time and services to see our patients. All the equipment for these two clinics was donated. Dr. Poore, again, he's been in the state for 50 years. He knows a lot of people, and kind of circled the wagons and got a lot of supplies and equipment donated. We are community supported and funded. In fact, one of our largest supporters is the Arizona Community Foundation through its Flagstaff office and the procedure we have there to get funding. We provide a number of different services. We outsource things like x-ray, lab, advanced imaging. And you talk about partnerships that can mean different things to different people. Now, we have some vendors in Flagstaff who give us very, very reduced rates. We have to pay for them. We're a 501c3 nonprofit, so we have to raise money to pay for that. Remember, because the patient gets these services at no cost. But they do help us by reducing those costs. We're looking at about 1,500 patient visits this year on the medical, dental, probably going to come in 500-600. And again, if I had more dentists, we could see more. We consider dental part of primary care, actually. An oral infection left unchecked could have other health ramifications, as I'm sure that you well know. We do have a small in-house pharmacy that we can dispense commonly prescribed drugs, antibiotics, and so forth. Other than that, our medical staff tries to, as much as possible, use that $4 prescription chart at the major drugstores and pharmaceutical companies. Some of our collaborators, we do have medical students who come through, nursing students who come through to work with our staff. North Country Healthcare is another healthcare system up there. So North Country has, let's say, educational program. They have a diabetes educational program. We don't offer those types of programs. We'll gladly refer our patients to services like that in the community. Flagstaff Shelter Services, starting a dialogue with them. Obviously, we're serving the same population, and figuring out ways that we can get their people to us who have that need. And we're always looking for help. We're always looking for ways to collaborate. One of the great things that we need is money and donations. So any of you who are in a position to help collaborate with us, like, we are certainly open to that. Supplies, vaccinations, we are really open to a variety of possibilities. I'm happy to say that we have our medical director here with us today, Dr. Doug Padgett. He'll be here all day. If any of you have any questions for him that are of a medical nature, or those types of services, he'll be here to answer those. Thank you very much.
So we have about 15 minutes for questions of the panel. And so I would ask those that are going to be roving mic holders to take their places, and we will entertain questions. This is your opportunity to participate. There's a question in the back on the right. You normally do not.
Bob England, Maricopa County Public Health, and in a very distant previous life, I worked a couple of years in an FQHC. For any of the panelists, it's quite a difference here between all the way from El Rio, which actually has more privately insured patients than uninsured, to a free clinic that won't even see somebody with insurance. I'd like any of the panel who wants to comment on either the reality or the perception of two-tiered healthcare, and whether they think it's important to try to attract regularly insured folks into the mix of their patient population to help dispel that. And if so, how?
I'm going to answer that, and this has been my experience with El Rio. We take the patient when they're uninsured. For some, we help them out with their medical care. After they get a job, they get insurance. Guess what? There are patients for life. Now they have insurance. That's the way that we have done it. When people come in through our eligibility process, we just don't assess the patient. We look at the whole family. And like you have seen, we have patients that maybe are not eligible for access or for the marketplace, but we might see dad might be eligible for the marketplace, baby might be eligible for access, and the mom might be eligible for sliding fee. So once we get, what's really important is to get the patient engaged. Once you have the patient engaged, you have them for life. Thank you.
Other questions? And if not, I have a follow-up question to Catherine, who does not receive any federal funds or state funds or local funds from the government. Might there ever be a time where your clinic would accept insurance?
We are certainly in that dialogue at the moment. At this point, we feel that the population that we serve is a population that is largely forgotten. And I think it's interesting that the topic today is health equity. What we're dealing with is the health inequity in our community. And because our model is volunteer-driven and we are mobile, although 2 of our 6 sites actually are part of hubs where we have wraparound services available for our patients, but essentially our model is bringing the doctor to the people. It really is not a model that we want to become, we don't want to grow it to become so cumbersome that we have to have qualifiers and billers and a whole additional layer of administration in order to take insurance. We want to be able to move quickly to the communities of greatest need. We work very closely with the Public Health Department. We work very closely with St. Joe's and Dignity Health on their Community Needs Index. And I think by being lean and mean and limber, we have more patients that we can ever serve. And it is tempting. There are some tremendous limitations we would have to put on our service, and we would have, I think it would be a challenge for us with some of our volunteer doctors. I'll tell you, our volunteer doctors say that working in a free clinic and having virtually no barrier between themselves and the patients is the reason they went to medical school. And frankly, I think we would lose a number of our volunteers if we went to an insurance accommodated model.
Yeah, ditto much of what Mission of Mercy's position on that is for the Poore Clinic. Dr. Poore founded our clinic specifically to address this need of people falling through the cracks. And it is in our mission statement, and it's in the paperwork we filed with the IRS to get our 501c3. So if we were to start taking insurance, we have to go back from scratch and start a new organization. I also say never. However, I'm frequently asked in Flagstaff about the Affordable Care Act. I have executive directors from other nonprofit organizations say, hey, Eric, is the Affordable Care Act going to put you guys out of business? Well, thank you. I hear lots of no's up here. I don't see that happening. If there comes a point in time where it's just no longer financially viable to do what we do for the number of people that we're able to help, then I think the board would look at that, we re-examine that. That's why I say never. But right now, for us, our mission is really specific. We're helping those folks who are falling through the cracks and who are in need.
Did I see a question in the back of the room there?
Good morning. Thanks for your presentations. Several of your organizations operate on a staff comprised of a large volunteer base, which I'm really curious about, and I think you just spoke a little bit to my question here. How have you cultivated this type of staff base, and what is the glue that makes this work?
As with the Poore Clinic in Flagstaff, we started off with a group of volunteers, and I believe that was a core value of Mission of Mercy. We do, for the first time, 3 years ago, we were able to hire a part-time volunteer coordinator. And that has made a huge difference for us because now we can look ahead and be more proactive, particularly as we see this huge increase in patient population. As I mentioned, our patient population has increased 40% in the last 4 years. So like the Poore Clinic, we are seeing more patients since the enactment of the Affordable Care Act. That was not what we anticipated. We looked at other clinics that were seeing a decrease, and we just assumed that would happen to us. I think all of those patients are finding their way to Mission of Mercy. So our numbers are up. So we have to be very, very proactive about looking for volunteers well in advance of any expansion of services or new clinic sites. Fortunately, we have a great relationship with the community, and we have a great relationship with the health community in particular, and we typically do not have a problem securing volunteers. Our volunteers are extraordinarily enthusiastic. They say it's the best day of the week when they volunteer with us. And as I mentioned, I think it really speaks to why they went into medicine in the first place. Now, in terms of our bilingual interpreters, which is a very key part of our culturally sensitive healthcare, we work with a lot of the community colleges that are training the medical interpreters, and we have cultivated the instructors and gotten people to come on tours of Mission of Mercy who are in a position to refer those students to us upon graduation. So we have, for the last several years, enjoyed quite a steady flow of medically trained and certified volunteers coming from the community college programs. Some of them are able to stay with us a year or two until they can find more gainful employment or a paid position. But even after that, they still try to find a way to come back and volunteer periodically. So the volunteer situation at Mission of Mercy is what we call a reciprocal blessing. And our volunteers love being with us, and we couldn't operate a day without them.
There's a question on this side of the room.
Quick question, I guess, for all of you. For those of you who accept federal and state funding, about how much of your budget is that approximately? And for those of you who don't, how much of the time of your organization goes into fundraising?
Get Native Health for our new budget, which just began October 1st. We're about 45% grant and federal funded, and the rest is through third-party billing.
I'm not too sure, so I'm not.
Yeah, so as part of the reason Dr. Poore and Mrs. Poore brought on an executive director was to address fundraising. So that is a primary responsibility of mine, as well as overseeing the administration and moving the organization forward. As an organization, though, if you totaled the hours of all our volunteers to some total number, it would not be that great. That's largely on me. We have a major fundraising event in September, and we write grants and then private donations throughout the year.
On a hospital and healthcare association. My question was about the social determinants of health, and it seems like, especially with Native Health and a couple of other clinics, you really spend a lot of time talking to these patients about not just their medical acuity, but also things outside of the four walls of your clinic. So I was wondering, what other specific ways do you guys address social determinants of health? And if you think you're succeeding in those areas, how and do you actually partner with other health systems and healthcare organizations to kind of share those lessons learned?
We do it. I can't say we're a success at it. I think we're at the very beginning of what needs to be done at Native Health to be able to work on that. One of the things we're going to be working on in 2016 is the Health Equality Index by the Human Rights Campaign. And part of that is going to require us as an agency to really do a lot of self-introspection about who we are, what we do, how we serve people, what are the areas that we need growth and training on. And it's a process, and it's an ongoing process. And as a nonprofit, we're also challenged by, as Ed mentioned kind of early on, that there's a whole political side to health inequality. And to be able to address that and work with that, because that also is where you also begin to work on some of those social determinants of health. And knowing who you are as a provider and what your foundation is and what your mission is, and being able to stick with that and continually work at the challenges that you need to address that. So we've got a long way to go still as an agency, even though we feel we're doing it every day. And a lot of that is just basically allowing people to come in and tell their story. If you don't allow that time, then you're going to miss a good part of what's going on in these people's lives. And so the starting point is to make sure that the patients that come in your door, whether it's through medical, needing behavioral health services, or through behavioral health, needing medical services, the only way you determine what their needs are is to take the time and listen to the story they have to tell as you're providing those services.
And as a opportunity and in the spirit of collaboration, short of finances, short of money, this is a room of resources. What is one thing that each of you need at your organization that may be in this room from a collaboration standpoint? We'll just start here and go to the end.
We are very, very anxious to incorporate some kind of a dental provider at Mission of Mercy. Not that we would do it ourselves, but we would like someone to come along beside us and help us with the dental piece. The other thing that I'm working on, and I've been working on for several years, is creating a business partnership with hospital anchor partners in each of our communities we serve. And we're calling this the ER Diversion Medical Home Initiative, where we can work with hospitals at the point of discharge for them to get those patients resourced over to Mission of Mercy clinics for their primary health care as an incentive to reduce those unnecessary readmissions. So for us, a third source of revenue would be ongoing hospital partnerships that are a win-win for both Mission of Mercy, the hospital, and most specifically the patient, to keep them in a medical home.
Thanks, Catherine. Dennis.
Because we are one of the unique providers and community health centers that has a comprehensive group of services, including behavioral health on site, There's actually a couple needs. One is we're looking to expand our psychiatry services this year, so if you know a good model for that, help out. But we're also lacking pharmacy in our center, and that's one of the areas we're looking for some creative ways to get pharmacy startup in our program, and are looking for some partners to help with that as well.
Thanks, Dennis. Catalina.
And I'm going to speak to all the public health students. What we need, our RIO is really comprehensive in everything. Right now, the greatest need that I see is that the patients do not, even though they have insurance, they might be in the marketplace, even on the sliding fee, they need to be educated. We need help, assistance. I need help, assistance in creating classes for these patients to know how to access health care. They have insurance, now they need to access health care.
Thank you. And finally, Eric.
I don't know if people in this room can help us with these things, but since you asked, I'll put it out there. My number one need is dental providers. I desperately need more dentists to volunteer their time. I'm backed up 4 months on dental appointments. That's how great the need is there. Certainly supplies like vaccines and that type of thing, which has a financial component as well. But another huge need that we have, frankly, is outreach. And so maybe there's some marketing minds, some public affairs minds in the room that could be of assistance. We opened our second clinic that has our dental clinic in a neighborhood that we know is a low-income neighborhood and has a transient population. Like Mission of Mercy, we also see and treat undocumented people. We don't even ask that question as part of our screening. And we know there's a tremendous hesitation in that population. And I get it. If I go around the community, here comes another gringo saying, trust me. Right, okay, I acknowledge that that reality exists. How do we break through that to help the people come in and get the care that they need that we're providing for free?
Thank you. Will you help me thank the panel?